Management of acute kidney injury in patients with COVID-19. Acute kidney injury is common among critically ill patients with COVID-19, affecting approximately 20 to 40% of patients admitted to intensive care, and it is considered a marker of disease severity and a negative prognostic factor for survival. Around 20% of patients admitted to an intensive care unit with COVID-19 require renal replacement therapy at a median of 15 days from illness onset. Pathophysiology of AKI in COVID-19. The cause of kidney involvement in COVID-19 is likely to be multifactorial, with cardiovascular comorbidity and predisposing factors like sepsis, hypovolemia, and nephrotoxins as important contributors. Virus particles were reported to be present in renal endothelial cells, indicating viremia as a possible cause of endothelial damage in the kidney. COVID-19 can directly infect the renal tubular epithelium and podocytes through an angiotensin-converting enzyme 2-dependent pathway and cause mitochondrial dysfunction and acute tubular necrosis. COVID-19-related immune response dysregulation generates a cytokine storm and development of microembolia and microthrombi in the context of hypercoagulability. Summary. Management of AKI in COVID-19, improving global outcomes. Recommend supportive care, avoidance of nephrotoxins, glucose control, monitoring of serum creatinine and urine output, consideration of hemodynamic monitoring. Mitigation of volutrauma and barotrauma through the application of lung protective ventilation lowers the risk of new or worsening AKI. Adjust fluid balance according to volume responsiveness and tolerance assessment. This strategy aims to restore normal volume status to avoid volume overload and reduce the risk of pulmonary edema and right ventricular overload. Renal replacement therapy should be considered in patients with volume overload, especially those with refractory hypoxemia. Early initiation of RRT and sequential extracorporeal organ support seem to provide adequate organ support and prevent disease progression. Continuous RRT is the preferred modality in hemodynamically unstable patients with COVID-19. The right jugular vein is the preferred catheter insertion site due to the use of prone position. In CRRT, regional citrate anticoagulation is more efficacious than other anticoagulation methods in terms of prolonging the extracorporeal circuit lifespan and reducing the risk of bleeding. Dose: low molecular weight heparin of 3 mg height, unfractionated heparin initial dose of 10 to 15 IU/kgh. CRRT should be delivered with a minimum dose of 20 to 25 ml/kg per hour. Extracorporeal treatments don't compromise the experimental antibody-based therapies like tocilizumab and 4-immunoglobulin. Summary. Thanks for watching.